Hello everyone and welcome to my channel. So today we will discuss the examinations of the surgery, and the important examinations in surgery are discussed in the following table. That is, these are the important clinical examinations. The first one is inguinoscrotal area and hernia, then umbilical hernia and paraumbilical epigastric or incisional hernia, then lump or swelling, the examination of breast, the examination of neck swelling, salivary glands, examination of ulcers, examination of varicose veins, examination of peripheral vessels, overview of the examination of abdomen, examination of lymph nodes, and examination of peripheral nerves. These are the clinical examinations and short cases important to learn in the field of surgery. Now we will start from the first one, that is inguinoscrotal area and hernia examination. So this is the examination of inguinoscrotal hernia. So let's start. First of all, what are the aims and objects of inguinoscrotal hernia? So after completing the examination of inguinoscrotal area, one must be able to answer the following questions. These are: is the swelling is coming through inguinal canal hernia or it is a true scrotal swelling? Then, if the swelling is coming through the inguinal canal, is it hernia or congenital hydrocele or infantile hydrocele? Then, if it is hernia, it is a direct inguinal hernia or indirect inguinal hernia. Then, if the swelling is scrotal, it can be arising from the testicles, that is tumor, then mass surrounding the testes like vaginal hydrocele and hematocele, mass arising above the testicles, that is epididymal cyst and spermatocele, encysted hydrocele of the cord, varicocele and epididymo-orchitis. In the following section, we will try to answer these questions. These are the important questions which we should learn for the examination of inguinoscrotal hernia. Okay, so now the first section, that is the swelling coming through the inguinal canal or it is a true scrotal swelling. So this can be easily differentiated by checking. If you can get above the swelling, that is hold the neck of the scrotum between the thumb and index finger using two hands simultaneously on both sides and try to feel the structures. If one can clearly get above the lump and feel clearly only the spermatic cord between the thumb and index finger, it's a true scrotal swelling. Like this. This is the inguinal ligament, and if you can get above the swelling, this is vaginal hydrocele. So if one cannot get above the swelling and feel structures which are thicker than the spermatic cord, it can be hernia, common or congenital hydrocele or infantile hydrocele. Now note in the diagram where a technique is shown to check the upper limit of the inguinoscrotal swelling. In this case, there is swelling in the right scrotal region and cord can be palpated between the index finger and thumb, indicating that upper limit of the swelling is reachable. Now note in this figure and sketch where the cord cannot be palpated as hernial sac is passing through it, so in the case upper limit is not reachable. This is inguinal ligament and it is that can't get above the swelling, and this is the hernial sac. So this was our first question about the hernia examination, that first of all we have to check that is the swelling coming through the inguinal canal or it is a true scrotal swelling. This can be easily differentiated by checking if you can get above the swelling, that is hold the neck of the scrotum between the thumb and the index finger like this, and using two hands simultaneously, that is this, on both sides and try to feel the structure. If one can clearly get above the lump and feel clearly only the spermatic cord between the thumb and index finger, it's a true scrotal swelling. If one cannot get above the swelling and feel structures which are thicker than the spermatic cord, it can be hernia, common or congenital hydrocele or infantile hydrocele. Okay. Now coming towards the next question, that is, if the swelling is coming through the inguinal canal, is it hernia, congenital hydrocele or infantile hydrocele? This can be easily differentiated by observing the expansile cuff impulse. Okay, to check this, that is the swelling is coming through the inguinal canal, is it hernia, congenital hydrocele or infantile hydrocele? So for this you have to do the cuff impulse. This can be easily differentiated by observing the expansile cuff impulse. Cuff impulse test should be performed in standing position but can also be performed in lying position. The patient is asked to turn his face away from you to avoid salivary shower. and look carefully at the inguinal area. If a swelling already exists, it will expand during coughing or more abdominal contents are driven into the sac. If there is no swelling, it may become apparent on coughing. In some thin individuals, oval-shaped bulge may be seen on coughing above and parallel to the medial half inguinal ligament. That is Malgane bulge, which is a normal phenomena. Presence of the expansile cuff impulse is almost diagnostic of a hernia, but its absence does not exclude the hernia. Okay, so what we have done in the second part, that we will check if the swelling is coming through the inguinal canal. Is it hernia, congenital hydrocele, or infantile hydrocele? So this can be easily differentiated by observing the expansile cuff impulse. Cuff impulse test should be performed in standing position, but can also be performed in lying position. The patient is asked to turn his face away from you to avoid salivary shower and look carefully at inguinal area. If swelling already exists, it will expand during coughing as more abdominal contents are driven into the sac. If there is no swelling, it may become apparent on coughing. In some thin individuals, oval-shaped bulge may be seen on coughing above and parallel to the medial half inguinal ligament, which is Malgane bulge and which is a normal phenomenon. The presence of the expansile cuff impulse is almost diagnostic of a hernia, but its absence does not exclude hernia. So this was our second question. Now coming towards the third part, that is now hernia or congenital hydrocele or infantile hydrocele. So first we have done the cuff impulse. Now we will check that whether it is the hernia or congenital hydrocele or infantile hydrocele. Now hernia, that is the expansile cuff impulse. It is expanded on cuff impulse, then it is usually reducible. Then the tympanic percussion note is present. Bowel sounds may be audible over the swelling, and no transamination or fluctuation is present. This is for hernia. If it is congenital hydrocele, then it is usually small in children, can be associated with hernia, and it is reducible, and it displays fluctuation and transillumination. If it is infantile hydrocele, then it is not reducible, no cuff impulse is present, brilliantly translucent, and displays fluctuation. These are the things for infantile hydrocele. So we will differentiate in the hernia, in the congenital hydrocele, and in infantile hydrocele this way. These are the specific points for the following things. So what we have done, first of all, we have find the cuff impulse, that if the swelling is coming through the inguinal canal, then we have to differentiate that whether it is hernia or congenital hydrocele or infantile hydrocele. So these are the points for hernia, that is expansile cuff impulse. It is usually reducible. Tympanic percussion note is present. Bowel sounds may be audible over the swelling, and no transillumination or fluctuation is present. Then we have discussed the infantile hydrocele, which are not reducible, and no cuff impulse is present, brilliantly translucent, and displays fluctuation. And the congenital hydrocele are usually small in children, and it can be associated with hernia, and it is reducible and display fluctuation and transillumination. Now another question is that how to reduce the hernia. Ask the patient to lie down on the bed. Direct inguinal hernia usually reduces spontaneously as soon as the patient lies down. If it does not occur spontaneously, ask the patient to reduce it, as patients usually learns the art of reducing it in long-standing hernia. In other cases, perform Texas maneuver, that is, ask the patient to flex the thigh and knee of the affected side and to adduct it. This will allow not only the pillars of superficial ring to relax, but also will relax the oblique muscles of the abdomen. The fundus of the sac is gently held with one hand and even pressure is applied to it to squeeze the contents towards the abdomen, while the other hand will guide the contents through the superficial inguinal ring. Now, what are the contents of the hernial sac? These are omentum, that is omentocele, intestine, that is enterocele, then part of the circumference of small intestine, that is Richard's hernia, and Michel's diverticulum, that is Litter's hernia. So, we have discussed how to reduce the hernia. For this, ask the patient to lie down on the bed. Direct inguinal hernia usually reduces spontaneously as soon as the patient lies down. If it does not occur spontaneously, ask the patient to reduce it, as patient usually learns the art of reducing in long-standing hernia. In other cases, perform Texas maneuver, that is, ask the patient to flex the thigh and knee of the affected side and adduct it. This will allow not only the plates of superficial ring to relax, but also relax the oblique muscles of the abdomen. The fundus of the sac is gently held with one hand and even pressure is applied to it to squeeze the contents towards the abdomen, while the other hand will guide the contents through the superficial inguinal ring. The contents of the hernia are omentum, intestine, part of circumference of small intestine, and Michel's diverticulum. Now, another question is how to differentiate between enterocele and omentocele. It can be omentum or loops of bowel. If the hernial contents are loops of bowel, that is enterocele, it is the first portion which is difficult to reduce. But in case of omentum, it is the last portion which is difficult to reduce, and also contents reductions occur with gurgling in case of enterocele. Okay. The percussion note over the omentum will be dull, while it will be tympanic if it is bowel loop. Bowel sound may be audible during auscultation over the swelling if its contents are bowel loops. The other tests like Siemens test, finger imagination test are less informative and no more performed. Okay, so in this method, using this method, you can differentiate between enterocele and omentocele. That is, it is omentum or loops of bowel. If the hernial contents are loops of bowel, it is the first portion which is difficult to reduce. But in case of omentum, it is the last portion which is difficult to reduce. And also contents reduction occur with gurgling in case of enterocele. The percussion note over the omentum will be dull, while it will be tympanic if it is bowel loop. Bowel sound may be audible during auscultation or the swelling if its contents are bowel loops. The other tests like Siemens test, finger imagination test are less informative and no more performed. Now the next one is that if hernia, then is it direct hernia or indirect hernia? This can be differentiated by performing deep ring occlusion test. The deep ring is situated 1.25 cm above the midpoint of the inguinal ligament, which lies midway between the anterior superior iliac spine and pubic tubercle. Femoral artery is located midway between the anterior superior iliac spine and pubic symphysis, which is called mid-inguinal point. Now, how to perform the occlusion test? This test should be better performed in lying position. Ask the patient to reduce the hernia or reduce it yourself. Identify mid-inguinal point between the pubic symphysis and anterior superior iliac spine and occlude it with your thumb. Use your right thumb for left side and left thumb for right side. Ask the patient to cough and note whether the hernia appears or not. Swelling will not appear in the case of indirect inguinal hernia, but it will appear if it is a direct inguinal hernia. This is the important point. Then, once it is confirmed that the patient is suffering from the inguinal hernia, never ever forget to perform abdominal examination for any mass, chest auscultation, cough, urethral palpation for urethral structures, and prerectal examination, that is benign prostatic hyperplasia, rectal tumor, to rule out these conditions as they may be the causative factors for hernia formation. Okay, now note in the first figure that left inguinal hernia reaching up to the scrotum, and in the second figure, hernia has been reduced manually and deep ring has been occluded by a thumb and patient is asked to cough. There was no appearance of hernia in spite of cough, which indicates indirect inguinal hernia. Now, how to palpate the urethral strictures? Palpate the urethra in the midline at the ventral surface of the penis. Strictures can be palpable as induration. Now, how to differentiate the inguinal hernia for femoral hernia? Okay, so up till now what we have discussed? We have discussed this is the hernia direct or indirect. So for this we will perform the ring occlusion test. And how the ring occlusion test is performed, we have discussed this. Then if the swelling will not appear in the case of indirect hernia but it will be appear in the case of direct swelling inguinal hernia. Then we discuss how to palpate the urethral structure, and now how to differentiate the inguinal hernia from femoral hernia. So inguinal hernia appears through the external ring above the and medial to the pubic tubercle, while femoral hernia appears through the femoral canal below and lateral to the pubic tubercle. Note in this finger, inguinal hernia on left side and femoral hernia on the right side is present. If the swelling is scrotal, it can be arising from the testicles, that is tumor, mass surrounding the testes like vagina, hydrocele and hematocele, mass arising above the testicles, that is epididymal cyst, spermatocele and cyst hydrocele of the cord, and varicocele and the epididymo-orchitis. Now when upper limit of the swelling is reachable, that is you can get above the swelling, then you can palpate the cord above the swelling, then the swelling is considered a scrotal swelling. During examination of the scrotum, do not forget that it has anterior and posterior aspects. Whenever you find any lesion on scrotal skin, perform all tests required for diagnosis of any lump or ulcer. Scrotum is examined by supporting it on fingers of both hands while feeling the testes or any other swellings between the index finger and the thumbs. Now the differential diagnosis of the scrotal swellings are testicular mass. A mass in the testicles proper suggests tumor, carcinoma or fibroma of the tunica albuginea. This does not transilluminate. It is often non-tender with palpation. Then another differential diagnosis is the mass surrounding the testicles. It is hydrocele. It is often quite and firm. It is transilluminates well unless it is quite large and then a very strong light source is needed. The fluid of the unless is quite large and then the fluid of the hydrocele surrounds the body of the testes, making the testes impalpable. This is the most important relation. If you can feel the testes separate from scrotal swelling, then swelling cannot be a hydrocele apart from insisted hydrocele of the cord. When hydrocele is lax, it is possible to feel the surface of the testes through the fluid, but this uncommon sign is easy to recognize. So this was a differential diagnosis of scrotal contents. Now mass above the testicles. This is epididymal cyst and spermatocele and insisted hydrocele of the cord. So the epididymal cyst, they represent the cystic degeneration of the epididymis, often bilateral. It feels tiny bunch of grapes. It is situated behind the body of the testes and is multilocular. It has clear fluid content and brilliantly transilluminate. Then spermatocele, it is unilateral acquired retention cyst derived from some portion of sperm conducting mechanism of epididymis. It is filled with the fluid resembling barley water and contains spermatozoa. It is unilocular, situated behind and above the testes and looks like the third testis. Insisted hydrocele of the cord is proximal and distal portion of processes vaginalis gets oblated and central portion persists, fluid accumulate in it. Then varicocele. A varicocele is a dilated mass of veins like varicose veins of the leg. They are almost away on the left side. They feel like a bag of worms and they disappear on supine position unless they are caused by a retroperitoneal mass of the tumor. Now the epididymo-orchitis. Remember that the epididymis is behind the testes, so epididymal disease involves the back of the scrotum. Never forget to examine the posterior surface of the scrotum. In acute epididymo-orchitis, the scrotal skin may be hot and tender epididymis, and in severe cases, it may not be possible to differentiate testes from the epididymis. In chronic epididymo-orchitis, the epididymis may be hard, knobby, and the whole spermatic cord may be thickened. The vasa deferens is often irregular, swollen, and feels like a string of the beads. So this was the general concept. Now these are the steps of the examinations of inguinoscrotal area, and these are the umbilical, paraumbilical, epigastric hernia or incisional hernias. And then these are the steps of examination for umbilical, paraumbilical, epigastric or incisional hernias. And then this is the swelling or lump. Okay, so up till now we have discussed the examination of inguinoscrotal hernia, that what are the important points that should be examined. So these are the questions. We have discussed each 4 questions one by one. The first one is that is the swelling coming through the inguinal canal or is it a true swelling? Then the second one is that if the swelling is coming through the inguinal canal, then it is hernia or congenital hydrocele or infantile hydrocele. Then We have learned how to reduce the hernia, then how to differentiate between the enterocele and omentocele. Then if it is hernia, then it is direct hernia or indirect hernia. Then we have discussed that how to perform the ring occlusion test. Then how to palpate the urethral structures and how to differentiate the inguinal hernia from femoral hernia. And if the swelling is scrotal, then it can be the following. And when upper limit of the swelling is reachable, then we have discussed the differential diagnosis of the scrotal contents, which are testicular mass surrounding the testicles, mass above the testicles, which are epididymal cysts, spermatocytes, and encysted hydrocele of the cord, and varicocele, then epididymoorchitis. And now we will discuss what are the steps of examination of inguinoscrotal hernia. Okay, now what are the steps of examination of inguinoscrotal hernia? So first of all, greetings, and I am Dr. Desh. What is your name, what is your age, and what is your profession? Can I examine your groin? And during this examination, if you feel any discomfort or pain, please let me know. Ask the patient to expose the area and take off the trousers and fold up the shirt and stand him up and note the following things on inspection. Screen and privacy should be provided. Exposure epigastrium should be visible and observe from the front and the side. Then cite the size, the shape, the number, and the inguinal or inguinoscrotal or pure scrotal lesions are checked. Note whether the swelling is above or below the inguinal crease. Scar mark previous herniorrhaphy and appendectomy. Overlying skin is checked. Position of the penis, that is deviation to the opposite side, indicates hernia. That is left-sided deviation indicates the right-sided hernia. Back of the scrotum, you may lift the scrotum using both hands, holding its two ends between the index finger and thumb. Check for any other swelling apart from the hernial orifice and ask the patient to cough and see for inguinal, paraumbilical, or epigastric swelling. Then during inspection, don't forget to ask any history of the pain, duration of the swelling, reducibility, effect of coughing or sneezing, chronic cough, urinary or bowel complaints. So you have checked for these things first. Then palpation is done. This was the step of inspection. Now after inspection, palpation is done. So for palpation, warm your hands, ask for pain, and inform if that you are going to touch him. Now check for the temperature with dorsum of the hand and tenderness, and check temperature before wearing the gloves. Then try to get above the swelling in inguinal hernia. Upper limits is not reachable. If swelling is large, hold it between thumb and index finger and ask the patient to cough to check for expansile cough impulse. If hernia is small, just put the palmar aspect of your fingers on it and ask the patient to cough and feel the expansile cough impulse. Check the relation of the swelling with pubic tubercle above and medial inguinal hernia below and lateral and femoral hernia. When upper limit is not reachable, ask the patient to lie down, reduce the hernia, and perform ring occlusion test to decide whether it is direct hernia or indirect hernia. Percus for the swelling, tympanic node indicates bowel loose, while dull node is indicator of omentum. Then check the inguinal lymph nodes. Auscultate over the swelling. Presence of the bowel sounds indicate bowels loops in the sac. Okay, then during examination, ask about any difficulty in urination, urgency, constipation, cough, and abdominal mass. Now palpate urethra for strictures to do digital rectal examination if there is any history of the constipation or urinary bladder outflow obstruction. Then palpate the abdomen for mass or ascites. Auscultate for any rhonchi or crepitation of the chest. Remember to auscultate the posterior aspect and sides of the chest. Cover the patient and pay thanks to him or her. When the upper limit of the swelling is reachable, perform fluctuation and transillumination test and measure the size as well. For epididymal cyst, pull the testes down and look for any movement of the swelling with this maneuver. For varicocele, feet like a bag of worms. Ask the patient to lie down and see if swelling disappears. Now, examiner will ask you to describe the case. That is, describe your examination with confidence, and your description should be with the same sequence as your examination, inspection, and palpation, etc. Now, the description of the indirect inguinal hernia is that this young man presents with painless inguinoscrotal swelling for 1 year that appears during standing and disappears during lying position. The overlying and surrounding skin is normal and there is no scar mark visible, peristalsis or prominent veins. It displays expansile cuff impulse on the cuffing. The temperature over swelling is comparable with the opposite side and it is not tender. It has smooth surface, soft consistency, and I am unable to get above the swelling. It is reducible through a point above and medial to pubic tubercle with gurgling sound, and on pressing the deep ring with thumb and asking the patient to cough, it does not appear. The posterior surface of the scrotum, testis, urethra, and DRE abdominal examination, inguinal lymph node, and chest examination are unremarkable. This is the presentation of the indirect inguinal hernia. Now the description of the inguinal hernia. This old man presented with painless swelling in the right inguinal area. They disappears during the lying and becomes more prominent on standing position for 6 months. The overlying and surrounding skin is normal and there is visible transverse scar mark over the suprapubic area. TVP done 2 months ago. The swelling displays expansile cuff impulse on asking the patient to cough. The temperature of the swelling is comparable with the surrounding skin and it is not tender, and upper limit of the swelling is not reachable. It has smooth surface, soft consistency, and display expansile cuff impulse. It is reducible and is not controlled on pressing the deep ring. Rest of the relevant abdominal examination, hernial orifices, inguinal lymph nodes, and scrotal examination and DRE is unremarkable. Okay, now the description of the vaginal hydrocele. This old man presents with painless swelling on the right side of the scrotum for 5 years. Overlying and surrounding skin is not discolored and penis is shifted slightly towards the left side. There are no visible vein scar marks and it does not display expansile cuff impulse. The temperature over it is comparable with the opposite side and it is not tender and I can get above the swelling. It is about 8 into 10 cm globular, not reducible swelling with the smooth surface and soft consistency. The swelling displays fluctuation and transillumination. Ipsilateral testis is not separately palpable but contralateral testis is possible and it is of normal size and shape. The rest of the abdominal examination, inguinal lymph node, GRE, and examination of the hernial orifices is unremarkable. Now the description of the testicular tumor. This is a middle-aged man presented with painless scrotal lump for 6 months. Overlying and surrounding skin showed to abnormal discoloration, no visible scars, veins or abnormal pulsations, and it does not display any expansile cuff impulse. Temperature over the swelling is comparable with the surrounding and it is non-tender. It is about 5 into 8 cm lump having smooth surfaces, firm to hard in consistency, well-defined borders, not separable from testes, and I can get above the swelling. It is not compressible, does not display fluctuation or transillumination. The ipsilateral epididymis and contents of contralateral scrotum are normal. Abdominal examination reveals a firm mass in the epigastric area and maybe para-aortic lymph nodes. The rest of the relevant examination, chest, supraclavicular lymph nodes, inguinal lymph nodes, and examination of the spines is unremarkable. Okay. Now, before you start the examination of inguinoscrotal swelling, you must be able to answer the following questions. What is hernia? What is direct and indirect hernia? What is femoral hernia? What is hydrocele and what are its various types? What is epididymal cyst? What do you know about testicular tumors? What are the treatment options? Boundaries of the inguinal canal, contents of the spermatic cord, various treatment options, indications of the laparoscopic inguinal hernia repair, and the complications of the hernia repair. You should know all these topics. Okay, so in the first section we have discussed the important questions related to the hernia, that is examination of the inguinoscrotal hernia. Then we have discussed the in this section we have discussed the common steps for examination of inguinoscrotal hernia. So these are the following steps. First of all, greetings, and then the inspection, then the palpation, and then now examiner will ask to describe your case and the description of indirect inguinal hernia and the description of direct inguinal hernia. You must know that how you will present the different types of hernia. So if it is the direct hernia, then this is a description. For indirect hernia, this is the description, and description of the vaginal hydrocele, the description of the testicular tumor, And in the next section, we will discuss the umbilical, paraumbilical, epigastric hernia or incisional hernia. Okay, now the umbilical, paraumbilical, epigastric hernia or incisional hernia. Okay, so the congenital umbilical hernia. In the fetal life, the umbilical vessels enter the abdominal cavity through a gap in the abdominal wall, and after birth, this gap is closed by a scar tissue, and the skin at this side is inverted as umbilicus. This is the skin temple. So, if the umbilical scar fails to form or is weak, the abdominal contents bulge through this weak point and avoid the umbilicus, leading to the condition called congenital umbilical hernia. Now, this gap is not closed up to 2 years of the age, and gap more than 2 centimeter, then it requires surgical repair. The acquired umbilical hernia. This was the congenital umbilical hernia. Now, this is the acquired umbilical hernia. In acquired umbilical hernia, the scar is there, but it is stretched due to raised intra-abdominal pressure, ascites, tumor, and avoids the umbilicus. This is the figure showing acquired umbilicus hernia. Now, paraumbilical hernia. In paraumbilical hernia, the hernial orifice is at the side of the umbilical scar, so the sac bulges out through any side of the umbilicus and turning it into a crescent-shaped slit as shown below. Figure demonstrating the paraumbilical hernia. This is the paraumbilical hernia. This is the figure showing the acquired umbilical hernia. And this is the figure showing congenital umbilical hernia. Okay, now epigastric hernia. It is protrusion of extraperitoneal fat or small peritoneal sac through a defect in the linea alba, somewhere between sternum and umbilicus. Incisional hernia. A hernia through an acquired scar in the abdominal wall caused by previous surgical operation. This is incisional hernia. Okay, so on inspection, check the standing position. That is the site, the size, the shape, the overlying skin, the umbilicus, the visible scar mark, and ask the patient to cuff to see expansile cuff impulse. Now on palpation, supine position is taken and check the hernial orifices on palpation. Ask for any pain, temperature, tenderness, surface, consistency, expansile cuff impulse, and reduce the hernia and palpate the defect and measure the size of the defect. Insert your fingers inside the gap and measure its size. Then palpate the whole abdomen to find out any other mass. Do percussion if needed. Auscultation of the abdomen is done. DRE, that is digital rectal examination, is done. Examine the chest for any added sounds. Cover the patient and thanks him or her. Now, how will you differentiate between the umbilical, paraumbilical, and epigastric hernia? In umbilical hernia, the umbilical scar is stretched by raised intra-abdominal pressure and thus umbilicus is avoided. In paraumbilical hernia, if the hernial orifice is at the side of the umbilical scar, so the sac bulges out beside the umbilicus and turning it into a crescent-shaped slit. In epigastric hernia, the umbilicus is inverted and normal. So this is the steps of the examination of the umbilical hernia. First of all, the greetings, the approach, and then inspection is done. On inspection, the side, size, shape, overlying skin, umbilicus, visible scar mark, and then ask the patient to see the expansile cuff impulse. Then inspection on palpation, check hernial orifice on palpation, ask for any pain, temperature, tenderness, surface, consistency, expansile cuff impulse, and reduce the hernia and palpate the defect, and then palpate the whole abdomen to find out any other masses. Then how will you differentiate between the umbilical and paraumbilical and epigastric hernia? So these are that the umbilical hernia, umbilical scar is stretched, and in paraumbilical hernia, the hernia orifice is at the side of the umbilical scar, and in epigastric hernia, the umbilicus is inverted, that is normal. In the next section, we will discuss the swelling or the lump examination, all the important points related to it, and the examination steps of the lump. Then we will discuss examination of the breast and all the steps related to the examination of the neck swelling. Thanks for watching.